Hey, good afternoon, everyone, and welcome to Grand Rounds. And thank you so much for all of you who have made it down to the auditorium today. We really appreciate your support, and I know that Garrett does as well. Um, the Cloud CME session number 2442. Again, 2442. And if you have any problems, just let me know. You can email or call me. All my contact information is in Teams. As you can see, the speaker had nothing to disclose, but we wanted to make sure that that slide was available for you to see. I'm going to turn it over to Dr. Matson, who will introduce our wonderful speaker for today, and then we will go from there. If you have any questions after the presentation, Dr. Matson actually goes around with a microphone. And if you ever have the pleasure of seeing him dance around, he is literally running around the auditorium, going from side to side, getting all the questions. And we so appreciate that. But we do that for you folks on Teams so that you can hear the questions and get the answers. So, all right, I'm going to turn it over to Dr. Matson, and thanks so much.
All right. Hello, friends and colleagues, and welcome to Grand Rounds. Today, we have the pleasure of hearing from one of our own, Garrett Getz. He is a clinical data analyst here at Dayton Children's Hospital. He graduated from Hiram College in 2013 and went on to work as a U.S. Navy Arabic linguist from 2013 to 2019. He then returned to the classroom to obtain a Master's of Health Informatics at the University of Cincinnati from 2020 to 2021. He joined Dayton Children's in 2022 as a health equity data analyst, where he performs data querying, analysis, and visualizations to help us better understand the obstacles to healthy lives through the interdependence of data, technology, and the human experience. So please give a warm Dayton Children's welcome to Garrett Getz.
All right, thank you. Yeah, I am Garrett Getz. I am the Health Equity Data Analyst here. I work with the Center for Health Equity in the Clinical Analytics Department. Today, we are going to be talking about data and health equity. So thank you for joining me with my presentation, Making the Implicit Explicit. So just to go over, whoops, that's the wrong computer. Maybe. Sorry.
Sometimes it has a hiccup.
You just give it the old percussive maintenance.
Try now. Well, I would just stick with
Okay. Oh, yeah, I can do that. That's fine.
that.
Perfect. Okay.
I'll see if I can't troubleshoot.
All right. No worries. All right. Sorry about that. Thank you, everyone. So today we are going to be going over how continuous improvement and quality improvement methodologies are applied to health equity, and also just healthcare in general. They apply equally to both topics. So we're also going to be talking about the role of data in CI and QI. And we're also going to be going over the importance of standardized data processes for health equity work. And again, that's also just for quality improvement, continuous improvement in general. Sorry if I get a little distracted here. I got like 2 keyboards I'm having to go with. So the first thing to really understand with data in this type of work is that data does not exist in a vacuum, and just on its own, it's pretty useless. That's probably blasphemy as a data analyst to say, but we really can't make decisions with the data until we understand the context that it exists in, the world that affects it. So again, we have to transform the data by putting it in context, by looking at the meaning of it. We transform it from this data to information to knowledge to wisdom. And that is how we use it. So again, we put it in context. We start to look at what the data actually says. It's not just a spreadsheet of ones and zeros or whatever. We have to put column headers on it. This is metaphorically put column headers on the data, and literally as well, so that we actually know what we're talking about and what this data represents. We look at it over time to see trends, and that's when we can start to actually make decisions with it. So as we're kind of building up here, we have this foundation of data. but we can't really do much without, understanding what the world is that it exists in. And another thing to really realize with quality improvement or continuous improvement in healthcare, making data-informed decisions to improve health outcomes is not a new concept. So I don't know if anyone recognizes this, but it is Florence Nightingale's data visualizations from the 1850s. So she, kind of applied the scientific method to a hunch that she had that a majority of deaths for the Army in the Crimean War were actually coming from preventable infections and not actual battlefield wounds. So she collected the data and aggregated it and put it into a visualization that we can easily understand. And we see in the center circles there, it's hard to see, but it is red, and those are the actual battlefield deaths or deaths from injuries related to the battlefield. The next sort of circle outside that is black, and that was all other deaths, excluding the next circle out, which is blue. And again, the area of these slices represents the actual number of deaths. So the blue was preventable infections, usually hospital-acquired infections during treatment. So through the collection of data and the understanding of it, the putting it into context and understanding the situations and all the contributing factors to it, that she was able to conclude that the leading cause of death for soldiers in the Crimean War was actually basically hospital-acquired infections. We have further work around the same time of folks kind of making data-informed decisions to improve health outcomes. Hopefully you know this name. If not, this is Dr. Ignaz Semmelweis. Also in the 1850s, that was a good time for using data to make smart health decisions. He worked for a hospital in Hungary in the 1850s, like I said, and he noticed that there were two different divisions that were delivering babies, and one of them had a much higher mortality rate than the other. So the first division was staffed primarily by doctors and medical students. The second division was staffed exclusively by midwives. The second division had the much lower mortality rate. So he sought to understand what the differences were between those two departments. Why was one having such worse outcomes than the other? And he concluded from the different staffing involved with each division, the one with doctors and medical students, they were also performing autopsies. And they were going from performing autopsies. They were washing hands with soap and water. We did have that knowledge at that point. But the midwives were not doing these procedures. They weren't performing autopsies. They're midwives, obviously. They deliver babies. That's the whole purpose. Oh. It's not a big deal.
Yeah, the laser pointer works now.
Okay, well, that's an improvement. Whoops. So he came up with this idea that basically the doctors and medical students who were performing autopsies had to be bringing something. Now he kind of, it was the 1850s. We didn't have great science back then. We had pretty good science, but he ended up concluding correctly that they were basically bringing infection with them, or, and that this could be prevented by implementing a sterilization process. He ultimately ended up using a chlorine solution to disinfect their hands, and eventually did see that decrease in the mortality rate. He did, like I said, he didn't necessarily have the most perfect example of scientific approach. So he, after kind of coming up with this hypothesis for why and coming up with a potential intervention, they didn't really test the intervention. They just went straight to implementing it. So it's not always a kind of the ideal way of doing it, but sometimes, we're seeing extremely high mortality rates. Sometimes urgency calls for not being able to go through the proper tests and do small tests of change, which would be ideal. So again, one final example, some of you may also recognize this, is John Snow's cholera map, again, the 1850s, great advancements. So again, seeing a trend, kind of getting a hunch, developing a hypothesis as to why we're seeing this cholera epidemic. Why is it, is it isolated to specific areas? Which, when he took the data and put it into context, actually seeing where these cases are occurring by graphing them or mapping them geographically, I was able to see that they were concentrated to specific areas. And what they eventually concluded was that this entire area was serviced by the same water pump. There was a part of the water pump that was basically tainted and leading to this cholera epidemic. So by simply replacing that part, pretty much went away. More or less, obviously, these things don't happen overnight, but you get a hunch, you collect the data, you see if it actually kind of proves your hypothesis, and then you develop a conclusion. Scientific method, that's kind of what we're working with here. But again, kind of the underlying theme with all these, man, come on now. And this is pretty much the golden rule of continuous improvement. You can't improve what you're not measuring, and you can't measure what you're not documenting. So all these people were able to achieve what they did and conclude what they did because of documentation. Data was being collected, data was being put into context. They were able to understand it, and draw conclusions. So they are pretty much pioneers, all of them, for medical advancements at the time that basically science we still use. So we are now going to jump to where we are today. Well, not today, but kind of where how we've gotten to modern times for quality improvement efforts in healthcare or continuous improvement methods in healthcare. Again, another thing I hope you all have heard of, the Errors to Human report. This was a report put out by the IOM in 1999 that, after a meta-analysis and meta-review of many different studies across the country, concluded that anywhere from 44,000 to 98,000 deaths were occurring in hospitals and healthcare facilities every year due to preventable medical errors. Obviously, that's just like a staggering number of preventable deaths. And a lot of this was coming from things that we now have a lot of protocols in place to deter different interlocks that hopefully should prevent these things from happening, like incorrect medication administration, not being able to read a doctor's handwriting, wrong site surgeries, things like this that were leading to completely unnecessary death. And just generally this call, this sort of wake up call of we have to be doing better and we can be doing better. Furthermore, 2 years later, we get another report by the IOM called Crossing the Quality Chasm. And this is, again, just kind of emphasizing, it's almost like a part two to Errors to Human. Of really, this is where we get the 6 aims, if you've ever heard that. Really this push for a learning health system of how can we use our knowledge, the data that is being produced, to effectively provide care and effectively provide the best care. So this really called out safety concerns, quality concerns, using not best practices, not evidence-based practices, and just in general, sort of healthcare providers not all being on the same page, again, with not having sort of the best, most up-to-date practices. And again, this also put an emphasis, on patient-centered care. So this is really kind of a shift in how care should be provided. So similar to Florence Nightingale or Dr. Semmelweis or John Snow, we see that there is something that's not going as it should in healthcare. Getting a hunch, getting a hypothesis of saying there are too many deaths happening that shouldn't be. There is, just too much inconsistency in healthcare in general in the US. So what do we do about it? How do we solve that? And fortunately for us, this has been happening in other industries for decades as far as how do we standardize processes to remove errors? How do we improve outcomes by analyzing processes and systems in general? So these are various quality improvement methodologies that you may have heard of or not, like Lean, Six Sigma, the Toyota production system with Kaizen, PDSA, PDCAs, all these sort of standardized processes for identifying errors in a system, identifying where there can be deviation in processes to ultimately reduce unwanted outcomes is how I would kind of distill those concepts down. Now, I'm not going to really get into the details of any of these. We do have continuous improvement and quality improvement professionals here who are far more knowledgeable and experienced. So if you are interested in learning more about those, I would reach out to those individuals. But one of the key concepts of pretty much all these, they are data driven. You kind of pretty much have to. It's the base of it from our first slide, right? That's how we actually learn is we start with data and we put it into context. So data is at the foundation of all these, and it's most of these cases are small tests of change and they're iterative. So you come up with an intervention, you test it for a couple weeks to see if it actually is providing the results you want. If it's not, you try something new. If it is, then we start to operationalize it and we expand it. Again, small tests of change. It's great for other industries. We'll get into it in a bit as to why this is a little more difficult for healthcare and pretty much impossible when we start talking about equity and when we start talking about closing the gaps in health outcomes and closing disparities. Spoiler, it's pretty much impossible because we can't correlate many of the inputs to direct outputs. So the systems are just far more complex. So we'll get to that slide here momentarily. Okay, so we have a methodology for improving things, right? We see that there's a problem. We know that we have these systems for improving them. And we also are at the same time, so again, we're kind of looking back at the early 2000s, we're getting a ton of data that is suddenly much more available. So as EHR adoption is increasing dramatically, we're suddenly getting a lot more data that we can actually use. So if you kind of think, and I'm sure some of you even have experience with this, back then, if you wanted to really try and look at trends in data over time, that mostly was manual chart review. We still have to do that, but now we can also use technology to our advantage to really glean information from the chart in a much more efficient way. So we have EHR use becoming far more prolific. It's generating just tons of data throughout the process of providing care. We're able to learn from that data much easier, and we're also able to share learnings much easier at that point too. But one little caveat here to all this is that EHRs were initially designed and implemented for billing purposes. That's kind of always comes down to money, right? So you know, we're collecting this data and all this data is being generated, but it's not necessarily for the purposes of actually improving health outcomes or not necessarily for the purposes of improving processes to make them more efficient, either by time or money, you know, reducing time that staff have to use on inconsistent or inefficient processes. So while we have this data, it's not necessarily the most usable for us. So just to recap that again, we're going to be doing a lot of things in groups of threes, by the way, today. So we have systemic issues, right? We have these established methods for improving systemic issues like that. And we also have a ton of data that we can use, right? Kind of. So easy solution. We can just use the data, we apply these methods, and we solve the issues. Obviously, no, it's not that easy. And the biggest thing is that healthcare is a fundamentally different industry. You know, a lot of those methods, like I talked about earlier, the Lean and Six Sigma, Toyota production method, it's in the name. They were mostly used for auto manufacturing, various manufacturing industries, a lot of things where production is automated. There's a lot of machinery involved, computers documenting and doing diagnostics, things like that. So there's just a far more complex system when we're talking about healthcare. And, we have different revenue models, different reimbursement models, different supply chain issues when we're talking about healthcare that kind of make it very difficult to adapt a lot of these concepts. And kind of the most fundamental of them, a human being is not a piece of machinery. A human being exists in a far different world than if we're just making a car, right? There's years of experience and context that feeds into that person and makes them who they are, and that also affects their health outcomes. So we have a lot more that we have to consider when we're talking about the context that the data exists in. There's a lot more contributing factors. We're not just kind of working in this vacuum of like a car being made that kind of, we have the supply chain, we have things going on inside, but for the most part, that production is kind of happening in a vacuum, at least compared to what a human is going through while they're receiving healthcare, while they're receiving care. So again, it doesn't happen in a vacuum. There's social context. We now know from the social determinants of health that these account for anywhere from 30 to 55% of a person's health outcomes. So all the things going on outside the clinic walls that affect them, like their housing, their transportation. Do they have a secure source of food? Do they have secure financial sources? What is their education or their job? All these things affect a person's health outcomes, and they are not really anything that we can control. When we're looking at processes that we can affect, it's mostly inside the clinic walls, and we know that that is only part of what affects a person's health. There's also the historical context to look at, especially when we're talking about equity. What is this person's experience with the healthcare system? What is their relationship with it? What's their experience of their peers? All these things affect a person's health. And again, it's really nothing that's ever been considered or had to be considered when we're talking about these continuous improvement methods from industry. Again, just humans are way more complex. That's pretty much it. And the bad thing with that is it's very difficult to account for all the ways that a person is complex and how they vary from machinery. Another challenge with this is also, again, the urgency versus timeliness. I kind of touched on this with Dr. Semmelweis. Most of these methodologies, like I said, are small tests of change. You measure, the results. You see if it's actually giving you the result you want, and then you implement it. We can't always do that. And especially when we're talking health equity, these are, again, affected by many contributing factors outside the clinic that we have very little control over, like, things going on in the community, different community programs, government programs. It just takes a long time to see results, if you see them at all. So we can't really do the ideal method of applying a intervention, seeing if we're getting results, seeing what those results are. We just don't have the time for it. And you'll kind of see later, the scale that this happens on is over years, not weeks or months. And also, we're talking about human lives. There's some urgency to this. Dr. Semmelweis was talking about maternal and infant mortality, which is something we're still talking about. We're dealing with people dying. We don't necessarily have time to wait always. Kind of already hit on this one, but further challenges because EHRs just really weren't built for these purposes. It's the tool we have. We're going to use the tool we have, and we're going to make the best of it, but it's not ideal. And we're working, to make them more usable. But you can't really count, or you can't really overcome the fact that they were initially created for billing, eventually kind of shifted for being able to assist in clinical decision making, but not completely intended for a systematic review or anything like that for a continuous or ongoing. They've been adapted to that, but that wasn't the initial intent. Further issues are human factors. Human factors are always going to be involved, even with when we're talking in industry. But we have even more to consider here because, again, the people are basically the data. We're not talking about a car. So you have the human to machine interaction, which this is really kind of when the providers are interacting with the HR or any of the software. There's always possibility for error, just a little typo. It happens. But that's one area where there could be error and introduce some reliability questions in the data. Second issue with this is that a lot of the data we're collecting is really coming from a human to human interaction, right? It's you all talking to patients, or another staff provider talking to a patient's family. So that just introduces even more opportunity for miscommunications, errors, making decisions off assumptions, and also introducing possibilities for unconscious bias. It's just kind of how it is. It's when you have two people, there's just twice as many opportunities for miscommunications. And another issue we run into there is the discomfort. So, when we start talking about race, or we start talking and asking patients about their housing situations, this can be uncomfortable for the patients and their families, but it's also can be uncomfortable for our staff to be asking that. So it's just another little barrier that we have to overcome that is not really an issue when we talk about trying to adapt like a lean methodology to healthcare. Oh, wow, I almost just skipped that one. Again, it's humans that we're working with here. They deserve respect and to be treated as humans. You have to, that's just another barrier that we have to be consciously considering is, are we respecting the patient when we're asking this? Are we treating them with respect? Are we respecting their response or lack of response? So all that to say that it's very difficult to actually adapt these methodologies to healthcare. But what we can do, and we definitely use some tools from them, different forms and just ways of doing things. But really what we've done is we've adapted some core concepts from them that we have basically applied to our equity action lab model, which is kind of our own little quality improvement / continuous improvement methodology that we've adapted. We've adapted it from the IHI and then also just our own learnings. So the first concept that we really can adapt from that and that we apply here is, what data is currently available and do we have the data that we need? So that's kind of question number one. Remember that one. And then further kind of building on that, we have, is the data actually usable? Is it being captured in a standardized way? So is it usable here, kind of meaning, is it actually in a place where we can find it? At least from a technology standpoint, we see a lot of times, obviously, that for clinical decision making, a lot of the information we need is included in a free text note. Just hint, that is my nightmare. So that is very difficult for a computer, and myself as the other one on the other side of the computer, to actually make any sort of significant use of that data. And then, the second point here is it captured in a standardized way, and that kind of feeds into the reliability of it. If it's not a standardized process for capturing this data, I can't really trust it, and therefore I cannot make decisions with it. Second concept, what is the context around the data? So this is kind of building on that pyramid from the beginning of, what is the world that this data exists in, and what are all the contributing factors that would affect it? Kind of a standard statistical thing here, statistician thing of check your assumptions. what do we know? What don't we know? How do we know what we don't know? And again, there's really no clear-cut way of doing that. It's just comes from kind of making a conscious effort of sitting there and actually thinking about what are we missing. It's hard to know what you don't know, but you at least got to try. And then the third concept that we can really distill from all these continuous improvement methodologies is where in the process is there room for deviation? And that's really what a lot of these processes are doing, all these methods, excuse me. Where in the process from point A to point B, is there any possibility for deviation? And can that lead to the unwanted outcomes? So again, when we're talking industry, unwanted outcome would be like a faulty thing being made, whatever. But when we're talking health and healthcare, those unwanted outcomes are often death or unplanned readmissions, disabilities, general unwanted results. Excuse me, sorry. And then the other part of that, when we're talking about decision making and room for deviation, is where are decisions being made based off assumptions and based off of subjective criteria. So if you're not really basing these decisions off objective criteria, that's when we start to go, okay, why not? Why aren't we? And obviously there's always going to be room in medical decision making for the professional decision making and professional experience. But that needs to be able to be quantified in some way or explained in some sort of objective way for us to really understand how that process should work and how that decision's being made. Is it being made in an equitable way? So I'm going to move to a real world example of kind of how we have applied those distilled concepts, those three concepts that we've taken from the different continuous improvement methodologies. And this does also sort of reflect our Equity Action Lab model before we officially kind of formalized it. So kind of harkening back to our initial three pioneers there, Florence Nightingale, Dr. Semmelweis, John Snow. We start with a hunch or a hypothesis. In this instance, our hunch came from very well-known national data. And that is looking at disparities in asthma ED utilization for Black children versus their peers or other white children. Excuse me, not other white children. Black children versus white children. So we know that this is a disparity that exists across the nation. It's well documented. There's been numerous studies that really show this. So we were tasked with kind of trying to close this gap in outcomes and close this disparity. So the first thing we did was look at what data is available. Do we have anything for this? Fortunately, because a lot of it are things we would be using for billing, and it's pretty standardized at this point. Yes, we do have data on ED encounters. Okay, great. We do have data on what is asthma. Granted, we did have to do some work to agree on this. We have to work with our clinical providers, our excellent pulmonary team to really see how would you define this versus how it's defined some other way, and what exactly is that objective criteria for what we would call an asthma ED encounter. So we did have that. And then we also do have patient race and ethnicity because we are collecting this. And this data point really kind of varies from the other two because this pretty much is being collected for the purposes of quality improvement and continuous improvement. Now, granted, it is a mandate from the federal government and has been for years, but this is how we use it and this is why it's being collected. So we have all this data. Awesome. That's a good start. That's the foundation of our pyramid there. Let's move on to our next questions here for it. Is the data being documented in a usable way? Again, a lot of it's being documented in discrete fields, which means it is usable. I can't actually find it. We have agreed upon terms of ICD codes that we can use. We have standardized fields where this data is being entered in the chart. We have standardized definitions of patient race and ethnicity. Now, granted, further questions there on the validity of it, but that's a different topic. And then further, we have to ask, does our data actually confirm our hypothesis? And as we did look into it, it undoubtedly did confirm that we do see the same disparities that we see across the nation among our own patient population. And that is that Black children with asthma at this hospital use the ED and go to the ED for their asthma just at a much higher rate than white children with asthma here. So we have confirmed that. We've looked at what data we have available. We have done our due diligence to make sure we can trust the data and that it's usable. We move on to concept number 2. What is the context that this data exists in? What is contributing to all these different outcomes? What are the different factors? And so we look at, the clinical processes. These are things we can affect directly, very easily. What is contributing to the ED utilization? How are we looking at what is considered like controlled versus uncontrolled asthma? Do we have processes in place for evaluating this to ensure that patients are getting what they need before they're having to go to the ED? And then again, this all happens outside the clinical space as much as it happens inside the clinical space. 30 to 55% of health outcomes can be attributed to the social determinants of health. So this is where we struggle, because while this significantly affects health outcomes, again, we're looking at things that we can actually affect, things that we can have some sort of control over. So when we're looking to the community and looking at what's going on outside our walls, we have to see what we can actually have an effect on. So what can we do about it? These are all things we have to consider, especially when we're talking about asthma. We know that asthma is affected by household conditions, different ecological factors. Here in Dayton, we have some ecological factors that contribute to our asthma disparities. What is the patient's home environment like? These are all things that we have to consider, and how is it affecting what we're seeing in the data? And then moving on to our third concept of where is there room in any of the processes that we're looking at, specifically in the clinical process or in how we sort of deal with the social determinants of health, where is there room in any of those processes for deviation? So we started looking at how someone's asthma is being controlled and how we're measuring that. So we look at the ACT score, the asthma control test. This is a pretty standardized test across the country for evaluating how well a patient's asthma is being controlled. So when we're looking for deviation, we see that there was really no standardized documentation for the ACT. It was being put into different parts of the chart. It was being entered in different formats. We have it in different flow rows. We have it in scanned documents. We have it just in a free text note. All this variation makes it extremely difficult to use this data to actually make decisions. And then we also saw that there was no standardized process for when and how the ACT was being administered. Specifically how often it was being administered. It was very random. And again, we're kind of calling back to what is the decision-making process for when this test is given? Is it subjective criteria or is it objective criteria? Is it just being made off assumptions? So after we kind of learned all that, we work with the clinical staff to standardize where it's being documented. We work with the staff to standardize how often it is and come up with a standard operating procedure and a policy that designates this. We, again, looking at the context, want to look at what's going on outside the walls and how we can affect that. And we also kind of want to use the tools that we already have in place, you know, using our tools effectively, using our personnel effectively. So we decided to go with the intervention of community health workers. We already have them here. They do a great job. They can help in the clinical space and outside the clinical space. And they were already working with several asthma patients. They can provide home assessments. They can help provide education. They can help provide different materials for in the home, like HEPA filters, cleaning supplies, mattress covers, things like this that are all well documented within the literature to actually reduce or help control asthma. So we settled on them as our intervention for this to help, decrease asthma ED utilization. And we kind of had to go through the same 3 questions with our intervention of what data is available on the patients who are working with the CHWs, right? So while we know that they do a lot of work and a lot of great work, we wanted to see, initially before we expand their work and, try to use this as an intervention of, are the patients currently working with the CHWs actually showing any improved outcomes? You know, sorry, totally just forgot where I was there. So what we found from that is that we, again, didn't really have a standardized way of measuring or even really documenting who the CHWs were working with. Again, sort of similar to the ACT, it was being documented in different places. It was being documented in different formats. All around, we just couldn't really do it. So again, similar to the ACT, we helped come up with a way of standardized documentation for this so that there was a flow row where a CHW could say, yes, this person is enrolled with us. This is the date. And, sometimes that's the easiest solution. It's just a yes or no, and here's the date. And for that, flow rows are beautiful to me. Discrete fields that we can pretty much do anything with. So we were able to standardize that process and standardize how we connected patients to the CHWs through that ACT score. So we have now standardized the ACT administration, standardized the criteria for connecting a patient to the CHWs, and then standardized how the CHWs are documenting who they're working with. And we've seen from that, and again, there are so many other factors contributing. So, I can use the laser pointer here. So this is a tool that I've created, and I can get into it a bit, but we started this intervention. Where's the laser at? There it is. Kind of around here of like spring of 23. And you can see that ED utilization for asthma for our white patients, which is the blue line, and our black patients, which is the orange line, has decreased pretty significantly since then. Now, granted, those 2 lines are moving pretty much in parallel, which means that the disparity still exists. That gap hasn't shrunk, which is what we ultimately want. We want everyone to be getting the same care, whatever care they need to have the same and equitable health outcomes. Excuse me. So as we can see, it is decreasing, but as I've said earlier, it's very difficult to connect any one input to the output, right? So there are so many factors contributing to whether or not a patient is having to use the ED for their asthma, whether or not their asthma is controlled. So while it does kind of occur at that same time frame, can we say that it is solely because of this intervention? No, we cannot. We'd like to think so. But again, we kind of have to take that Dr. Semmelweis approach of, we just kind of need to implement something that we are pretty confident will have an effect. We don't really have time to sit here and see if it will have the intended effect and if that effect is actually significant enough. Again, this is kind of over the scale of a couple years that we're finally actually seeing this needle move a bit. So if we did a bunch of little small tests of change iterations on a scale of a couple years each, maybe we'll see some effects in like 20 years. So we just kind of don't have the luxury of doing that. And like I said, this is a tool I've made that kind of helps simplify some of those questions, some of those concepts that we've adapted from the different methodologies. So we're able to investigate these concepts or these different metrics and define our populations to see how they compare against each other, so we can actually designate a reference group and a comparison group and compare how the different rates for different metrics are, basically investigate if there's any disparities in them. So we have gone over our three concepts and how they are applied. And now I kind of just want to offer up some hypotheticals or some real world scenarios here, and how we might apply those. So asthma, a chronic condition, as we all know, is a strategic priority of the hospital. Let's maybe look at some of the other ones and some of the barriers we might run into. So let's say we want to look at infant mortality. Most recent data from CDC, infant mortality rate for Black children is 2.4 times higher than for white children nationally. So if we apply those same three questions that we've kind of looked at for asthma, what data is available? What data is available specifically for us in our EHR? Frankly, not much. Most of the time, death and mortality data is in public registries or public health data, vital statistics registries. These are things that do not connect to our data sources, or at least not easily. It's something we're in the process of trying to get, but even then, there's so many more inconsistency of trying to connect two separate data sources. So when we're trying to come up with interventions, we really don't even have the available data within our own patient population to see where and why this is occurring. Furthermore, sometimes the only data we have is qualitative data, which I know some people like to dismiss. Qualitative data is data, and it does help give us the context that really informs a person's experience and what they're going through. It represents the voice of a person and their community. To dismiss qualitative data is kind of just to pretty much invalidate that person's experience. So sometimes that's all we have, though, and it can be difficult to make systemic decisions based off of qualitative data, but that is still data. Furthermore, another scenario, suicide prevention. If we're looking at communities who have been excluded or who have, worse outcomes than others, most recent data shows that LGBTQ plus youth are more than 4 times likely to attempt suicide than their peers. Again, starting with question number 1, what data is available? To simplify that answer, none, at least not for us. Not data that we can use to actually try and come up with an intervention that would actually, be effective. So I know that was a lot. Thank you for listening, but these are my final takeaways. I kind of hammered them home the whole time. Hopefully you were able to ingest them somewhat, but you can't improve what you can't measure. You can't measure what you aren't documenting. And one little caveat on that one, what you're not documenting discreetly in a usable way. If it's ending up in a note, again, that's for clinical decision making, that's great. But when we're talking about trying to implement systemic changes and make systemic decisions like that, it's not usable. Secondly, we can't effectively use data without understanding the context it exists in. The two are pretty much completely codependent. Data without the context is pretty much useless, and just kind of understanding the world without having data to support hypotheses or decisions, also not very effective. And then finally, just something to kind of think about in your own work is where in your clinic or where in your workflows is there room for deviation? Where are you making decisions based off assumptions? What are your decision criteria? Is it objective or subjective? And that's it. So thank you. I now take any questions.
All right, great presentation. I have a question. So you are the man behind the scenes looking at discrepancies and disparities locally. You have an audience full of providers and also online. Are there any discrepancies or disparities that you feel like affect our community that we need to be more cognizant of?
Whew. I think the biggest thing to be cognizant of, and not necessarily any one specific disparity, is that disparities do exist. They are real. They are often affected by factors that are completely or almost entirely outside a person's control. It's not done out of maliciousness or anything like that. And really, the only way you're going to be able to really understand why those disparities exist is by putting the data into context and understanding what the factors are contributing to that for that individual. So if you're speaking to a patient or their family, and you're hearing something, don't dismiss it. It's probably something that they have very little control over that is leading to this. So yeah, I guess just recognition that disparities are real would be my.
Well, and my follow-up question is for all the bright-eyed, bushy-tailed people in the audience that are considering doing QI or research projects to address said disparities, where would you suggest they get started in finding that context?
Yeah. Literature reviews, always a great place to start. I'm sure many med students just cringed like real hard at hearing that, but that's always, look to see what's already out there. Make efficient use of pretty well-known knowledge. Another plug that I will throw in there is that dashboard that I created is basically intended for that purpose of investigating where we may see disparities among our own patient population. And then really once you kind of identify one or you have a hypothesis or a hunch that one is existing somewhere, you really have to dig into the data to see, verify, where, how, what, all the big questions, I guess.
Is there a data collection database preferred at Dayton Children's? For example, when I did my fellowship, we had to use RedCap quite a bit. So I don't know what we use here.
We do not have RedCap, I don't believe, or at least not that I'm aware of. No, no, I don't think there's a preferred, at least not to my knowledge. Someone correct me if I'm wrong, but.
Any questions from the live audience?
I have one additional comment for all that. So we do have a lot of self-service data analytical tools that are provided by Epic, like Slicer Dicer, Workbench Reports, all these things that are kind of intended for clinicians and providers to do their own data analysis. So I would recommend looking into those tools. There's trainings provided by Epic. We also have plenty of data folks here who I'm sure would be happy to help and answer some questions.
All right, it looks like that's all the questions. Just friendly reminder, your session number is 2442. Once again, that is 2442.
Yeah, thanks. I wanted to reinvent the wheel. Yes, yes. Thank you, thank you. Yeah. great job.
I don't look at that. I
You
look
gonna
at
take photos?
but
Come on.
thank you so like I've had